Good afternoon, everyone. This is Leanne Griffin with FATA. We do expect to get started on time this morning, this afternoon, in about 5 minutes. So that'll be at 12 noon sharp we'll get started. I also wanted to point out that I have dropped in some technical information in the chat panel today that you might find helpful, and we'll reconnect in about 5 minutes. Thank you. Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Gender-Specific Trauma Treatment Strategies. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Do note that as an attendee, you are in listen-only mode and will only be able to view your own name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The icon to open the panel is usually located on the upper right side of your monitor. Use the Q&A panel to send any questions you may have as you think of them, and the presenter will answer those as time permits today. Also, I did want to point out something a little different about today's webinar. Dr. Sims has shared 2 case studies with us today. Those case studies are located as Case Study 1 and Case Study 2 tabs, and they will appear at the top of your PowerPoint presentation screen. You should be able to see them and access them there. However, if you have any difficulty clicking on those tabs and viewing those case studies, I have also placed them in the chat panel. So you can open your chat panel and go to the very beginning of the dialogue, and you can see case study number 1 and case study number 2. And of course, Dr. Sims will further address these when we get started. Our audio is being broadcast today through the internet to your computer. You must have speakers attached to your computer and have, of course, the correct software and your volume on. But if you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience a loss of audio or poor audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen as well. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 days. As many of you know, FATA produces many webinars through the support of the Florida Department of Children and Families. To help participants track credits earned through webinar attendance, we have launched a new website that provides a personalized digital journal where participants can maintain evidence of attendance for every webinar and workshop taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation on the FATA website. You will be prompted to register or log in to complete the evaluation. You may register as a visitor. And keep in mind that any information you provide FATA as part of registering does remain confidential. Also, as usual, completing the evaluation is necessary to receive CE credits or to access your statement of credit. Once your attendance and the evaluation are verified, you'll be notified that your statement of credit is available in your own member profile. Do be aware that the evaluation does close at midnight on Monday, April 2. Again, the evaluation closes at midnight on Monday, April 2. We expect posting of credits to take about 5 days, although we will try to work through verification earlier, if possible. You will receive an email from info@FATA when your statement of credit is posted. If you are a Florida licensed healthcare practitioner, Be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Do note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a statement of credit if you do not attend the entire webinar, and we're not permitted to provide partial credit. I'd like now to introduce our presenter for today's webinar. Brian R. Sims, MD, is a psychiatrist and national and international consultant on trauma-informed care. A trauma educator for the National Council for Trauma-Informed Care and the National Association of State Mental Health Program Directors. He has provided trauma-informed care training in the United States, Guam, Australia, New Zealand, and Japan. Dr. Sims previously was the Senior Director for Behavioral and Mental Health for ConMed Healthcare Management. There, he was responsible for the development of care strategic planning for the company's mental health provision in 9 states. Prior to that, Dr. Sims worked in the state of Maryland's mental health system for 25 years. A graduate of Meharry Medical College, he served for 3 years in the Army Medical Corps at Walter Reed Army Medical Center. And we're very pleased to have Dr. Brian Sims join us today. And if Dr. Sims, if you're ready, I'm going to bounce over to your presentation and then turn control over to you.
And thank you. Can you hear me?
I can hear you.
Okay, wonderful. Well, good afternoon to all. I have to first start off by giving a very special thanks to the Florida Alcohol and Drug Abuse Association and the Florida Department of Children and Families for this wonderful event that they have hosted, and also thank them for asking me to speak during this time. I'm very humbled by it, and I consider it to be a very much an honor situation for me because this is an extremely important topic to be talking about. You know a little bit about my background, that's fine, but I did want to add one more piece to it, is that despite any descriptions, which I don't particularly like to hear a lot in terms of describing things, I consider myself to be a person that has had multiple experiences of how people deal with trauma-informed environments. By no stretch am I to be called an expert in any sense. I've just had enough in my background to be able to share stories with you. And the purpose really of today is to provide you those examples and additional information intended not really to lecture to you, but hopefully provide you with more tools to place in your toolboxes. I know that those who are listening in are very dedicated individuals that have been a part of this field, and it is a difficult field to be working in. So I'm not here to prescribe or promote. I'm here to offer you additional information that will hopefully give you additional strategies to take away from today. What I wanted you to see before we get started is the obvious disclaimer between CMS, the Center for Mental Health Services, Center for Substance Abuse Treatment, as well as SAMHSA itself and HHS in terms of the standard disclaimer. The objectives for today really are very basic. What I wanted to do was just go over some of the trauma basics, a little bit of talking about the prevalence in the general population as well as the special populations defined as those of whom you work with. but not leaving out the fact that we look amongst ourselves. Also going to talk about the importance of addressing trauma by trying to understand more so what happened to individuals being served instead of focusing on what's wrong with them. We'll talk in the second portion of this talk about the adverse childhood experiences and its implication for treating and including the impact in terms of gender differentials. And finally, the healing and recovery from trauma and how, as one of the mantras that has been established through the National Center for Trauma-Informed Care, one does not have to be a therapist to be therapeutic. Now, I spoke a little bit earlier about the National Center for Trauma-Informed Care, but I just wanted to offer an additional component that this is an organization that is a SAMHSA grantee. I've been working with them since their inception in 2005. Our goal and premise is to establish trauma-informed environments by assisting individuals in the community to help work with us directly to transform these environments. And I'm very pleased with Dr. Joan Galise, who is the person who has been the spearheader and is our program manager. Now, to get started, what I wanted to do was go first to the SAMHSA 6 principles of a trauma-informed approach. Why this is an important starting point is because SAMHSA in its wisdom has been working for years on initially how to reduce the elements of seclusion and restraint. Through this, what they have realized is that if they take on a trauma-informed approach, there is a much more positive, long-lasting, sustained response that communities and individuals seem to show. So the 6 principles that I'll be reviewing with you just give you kind of an overview of SAMHSA's vision as well as the teachings through the National Center for Trauma-Informed Care. In these 6 key principles, the first and foremost is safety. And safety is something where in our organization we have a number of lived experience individuals that travel with us, and in speaking to all of them, they make the message very clear to us that one cannot feel safe without first finding their healing. Now, I want to pause for a moment because I just want to take you to the most recent information that you've been seeing on television. I want to mention a certain person I know that most of you have heard of by the name of Oprah Winfrey. And Oprah Winfrey, approximately 2 weeks ago, back on the, not the Sunday past, but the Sunday before that, appeared on 60 Minutes. And the story behind what she was able to present to us showed an individual that at a point in her life has now began to embrace trauma-informed perspectives. You can see this, I think it's called Healing from the Inside Out on 60 Minutes, but she also did an interview with her friend Gail King and disclosed during that time about how important it is for trauma-informed care perspectives to be understood, because as she quotes, one cannot address the person's issues without healing the hole in their soul. So as we look at this first principle, we can see it interwoven, that one has to feel safe, and not only safe amongst themselves, but also safety within the organizations that you work with. Because within that setting, what you do find quite often is that people don't feel safe in the very settings that they work in. And that safety can be personal, and it can translate as well into the environment that people work in. So the safety may look different. And it's important to take a look at this as a first step, because the best thing you can do is to try to help this individual or this organization to collectively determine how they would define safety and what feels safe for that person or for the organization. We take a look at the second principle. The second principle goes down the premise of trustworthiness and transparency. We look at organizations, we look at ourselves, we look at our families. When we conduct our business with each other in relationships, in the people we serve, in the organizations that we work for, one of the most powerful components is how transparent are our discussions. Are we conducting transparent, conversations with the goal of really maintaining trust. I think many of you who work in the outside fields and you're dealing with individuals of all age groups and all circumstances understand that trust really weaves into success with regards to connection, with regards to working with individuals, and it's imperative that we work with understanding how important that trustworthiness is in the relationship. We also understand that there are options within that. Because as you serve individuals, you need to help them to understand their options. Because when you open doors, we're going to get into further principles, but when you do that, you open doors to actually further connecting with individuals. One of the things that I've seen over time is that it matters not with regards to gender-specific components, whether you're male or you're female, if you're a boy, you're a girl, you're a woman, you're a man. People connect differently, and those connections can come in a very, very, very quick way. And I often ask a lot of groups, and I'll be using a lot of examples in our talk today, but I often ask a number of people in the groups, I will ask for a show of hands of those who feel that you can connect with someone in less than 30 seconds. And generally what I'll get are a few hands that raise. And then I'll ask a different question. I'll say, how many of you believe that you can disconnect with a person in less than 30 seconds? And generally, you'll see far more hands raised. And I'm bringing this point into the trustworthiness and transparency component of the 6 principles because we function more on a negative realm than a positive realm. And what do I mean? What I'm really saying is that we measure a lot of our connections more on the negative side. You look at hospital systems and morning report. What does the morning report emphasize? It emphasizes generally the negative behaviors that occurred the night before. And what that does, as you can well imagine, is it arms the person in all the wrong ways. Now what they're doing is going into the treating environment armed with all the negativity and hoping that they either don't have to deal with that or they have specific behavioral interventions that they want to do to work with it. But either way, trauma-informed care flips the script. It basically starts to promote looking at the positive. Any of you out there that work with adolescents, you want to take a look at that piece because very rarely, and I can see through the Q&As or the chat room or otherwise, how many adolescents have ever approached you and said, I want to sit down and process with you. For the most part, getting trust out of that adolescent really has to do quite a bit with the connection, and that connection can be very, very, very clean cut based on how we respond to people. If we come down the road of negativity, we get nothing. When we start to compare some of the things I'll talk about a little bit later in terms of value systems or otherwise, but when you involve them and empower them, you see that there's a tremendous degree of difference that comes out of the response that you see. We move then okay. I'm just going to get my slide to advance here.
And Dr. Sims, remember,
yeah.
It can be helpful to use your mouse and click inside the center panel to activate it. And then the page up and page down keys should work.
I appreciate that. Thank you so much. And I'll need you a couple more times, I'm sure, before this is done. But anyway, going back to what we were talking about, let's look at the next principle of trauma-informed approach, and that's peer support. And this is a focus that you see lots of organizations begin to embrace in a larger percentage now as we go across the country and really across the world. Because the understanding is that when peers are involved in treatment strategies, you find that you're able to build a tremendously more positive organization. Because what you're doing is establishing equals. And what does that mean? It really means that what you're doing is you're starting to get people to talk with each other instead of at each other. Many systems are using this on the premise of bringing in peer supporters who have been previously treated in that facility, not to use as behavioral interventions, but as individuals who may help take the trigger, the traumatic reminder, the stimulus that that person is having by just coming into the setting and settling it and being able to give that voice of someone with experience. Now, in our center, whenever we do trainings or technical assistance across the country, we generally will take a person with lived experience for that very same reason. It validates what we do. We look at this based on core values and principles. I was in a system in the Midwest, and we were taking a look at some changes on how they would cover things, and one of the problems that they were having was that they were experiencing difficulties at intake. People were coming in, they were highly agitated. The intake process was usually overlapped with 2 or 3 intakes, which further triggered individuals. And by the time they would reach their treatment area, many of the times they were so to a degree of hypervigilance that interventions had to take place. This particular system decided to approach it in a different way, and one of the ways they approached it was to go with what the Joint Commission on Accreditation of Hospitals is asked to do in every particular setting, and that is to ask the person first, what things do you value? And it's interesting because depending on age group, when you ask a person what their values are, it will range anywhere from their ability to tell you what their values are to crickets really flooding the room with sound. Because when you start to talk, for instance, to many adolescents, and you ask them what their values are, many of them are unable to tell you that. And one of the reasons why is because when we go back and focus on the negative approach, you find that they're really unable to tell you anything positive about themselves. However, if you ask them what are their deficits, then they can line those up and they can pretty much tell you from one point to the next. So looking at this from the lens of peer support, you have a highly agitated individual, they're hypervigilant, they are really charged with the triggers that have been coming at them since they stepped into your facility. To have a peer support person at that level validates, calms, gives them alternatives, helps to explain to them at a time that the procedures that you would like to see done are necessary, number one, but also are safe. The person has to feel safe. So it's a key vehicle for establishing that safety, for establishing that hope. Most importantly, for establishing the trust. Because what you're trying to do is set in motion a model for recovery for that person. Because in that, by doing it in a value-based system, as this organization did, it really empowers the person. What they did was they asked them, what are your values? And when they told them what the values were, they actually had the person write those values down on a card, and the person wore that card around their neck. But what was different about this was that they went then to the staff, and they asked each of the staff persons to identify their own individual values, and they wrote those down and placed them around their neck. So what would happen is the individual, as they're introduced to the group that they're going to be working with, the first thing that happened was that they would match that incoming person with a staff person who shared the same value, so that the opening conversation was centered around the same value. What that did was it brought them to equalize. It brought them to the point where they could discuss something that both sides were very comfortable with, and the person did not feel talked at, but instead of talked to. And it was wonderful in terms of how much that made a difference in how people address and begin that journey that takes them to the next phase of recovery. You look now at the 6 key principles, the fourth one being collaboration and mutuality. And here's a real tickler for many different systems, because collaboration is about partnering. And the partnering generally is where organizations don't have the greatest grip on the understanding of what it really means. When you're looking at trauma-informed perspectives, when you're looking at using trauma treatment strategies, you're looking at leveling the playing field. And in organizations, leveling the playing field means that you want to empower those who feel they have no voice. I will use examples of hospital systems again when we take a look at this, because in a lot of hospital systems, you have individuals who have the least amount of mental health training who end up being the persons that are in the face of the people you serve 24 hours a day, 7 days a week. If we are not empowering those individuals and giving them the sense that they are at the table of discussion of the treatment of the individuals, you're missing out on a tremendous amount of things that could be benefiting your system. In that, what you're teaching anyone, from the person with numerous degrees to the person, again, that may be labeled as a direct care worker or does not or has minimal training, what you're saying to them is that all voices matter. Every person is a part of the collective organizational team. And as a result, everyone has a role to play. One of the mantras we use also is that one does not have to be a therapist to be therapeutic. I use that example because I worked for the state hospital systems for about 25 years. And during that time, I can tell you that the person that stands out for me that was most effective in my environment was an individual that had no mental health degrees, and their job in our setting was to be a ward clerk. And if you're not familiar with ward clerks, these are individuals who go into our nurses' station here in the state of Maryland, and they will keep our charts together, they will answer our phone. So what made this young lady so effective? What made her special was every day as she came into our setting, the first thing she would do is walk into the middle of my 31 patients, and she would say to them, "Good morning, everybody." And all of my patients would say to her, "Good morning, Mrs. Queen." And it would be followed by her not just accepting that and walking away, but then she would go over to one of the patients and say something along the line, "Well, your grandmother was ill. How is she doing today?" And the patient would say, "Well, Ms. Queen, she's doing much better. Thank you so much for asking." She'd move to another one and she'd say to that person, "You know, you may have had some difficulties with your anger. How are you doing with that?" "Well, I'm still angry, but I'm okay." After she did that 2 or 3 times, she would then go into her nurse's station and she would proceed to do her duties of the day. And I challenged the group with the question of, what do you think would happen to this young lady if someone did something evil towards her or said something to her? What do you think would happen? Because I think we all know that when you make those simple connections, it changes the entire environment. I had 31 patients that were ready to completely challenge anyone that would say anything negative to her. And it grew more than that. It actually grew to different phases, where if I had 31 patients on my unit and 5 of them would be discharged and 5 more would come in, and those 5 did not know Mrs. Queen, they were quick to advise her as to who this young lady is and why it is that she is special. Well, if that were the case with the majority of our staff, one can only imagine how much power comes within that. So we want to take a look at those pieces, because the principles we talk about and the different strategies don't necessarily have to cost money. They do go back to relationships and how we relate to one another. Let's go to principle number 5, empowerment, voice, and choice. We have a number of trauma survivors, as I mentioned earlier before, and I do caution everyone that it's very hard to talk about trauma-informed perspectives without potentially triggering individuals. And I'm apologizing in advance, but in order to discuss some of the principles, I may bring up examples that could be triggering, and please take care of yourself if you find that these examples do the same. But when I'm looking at empowerment, voice, and choice, I'm recalling a trauma survivor who currently works with us, and his name is William Kellebrew. And William Kellebrew is a young man who, if you're not familiar with him, at age 10, he was in Washington, D.C., 1984. And at age 10, he witnessed the killing of his mother, who was shot 3 times in front of him. He then witnessed, seconds later, his 12-year-old brother being shot in the head in front of him. And the same gunman then put the gun to William's head. And at 10 years old, he begged for his life, and he was allowed to leave the house. And then the gunman killed himself. Where I'm going with this is, as horrible as the circumstance was, William repeated that he never felt he had a voice, that many times when given the opportunity, he would attempt to express himself. So 2 years after this event happened, at age 12, he goes to school. They ask him to write an essay, and the title of his essay is, "I Didn't Know Blood Could Fly," and no one in the system picked up the connection. He then makes very clear that the biggest change that happened in his life was when someone gave him a voice. And that was his therapist at Children's Hospital. She offered him the ability to make a choice. And even at his young age, it was something he saw as very changing for him. It began to reframe his thinking. Because in it is support, but also in it is that empowerment. It gives people the understanding that the roads that they travel are not unipolar. They don't necessarily have to lead what they think the road is going to lead to. But one more powerful piece that Empowerment, Voice, and Choice does is that it offers people the ability to break the field of this is just the way it is for me and it will never change. Otherwise known to many of the survivors as my belief system. Many know that within their belief systems, this is the way their life has been. And they understand the differential, but they really do not feel that their life will ever change until someone comes in and offers the support, but even more importantly, offers them the hope. So lastly, we move to the cultural, historical, and gender issues, because within this, I think really paints a larger picture of the types of things we need to be looking into. We know about stereotypes, we know about the biases, but we often don't bring them into the realm of our treatment ideas and our treatment attitudes. Because what tends to happen quite often is that whatever our personal experiences are, whatever our personal belief systems are, tend to blend into how we react to other ones. So this is about also educating individuals to try to actively move past those cultural stereotypes, move past those biases. Educate oneself in the realm that it's not always necessary to work with everyone. We do find sometimes that in treatment strategies, it's better if a person is triggering you not to work with that person and get someone else to work with that person. So within an organized system that is attempting to come down the roads of a trauma-informed approach, you have a balancing. You have people that can relieve you while you may relieve someone else. We also want to leverage that healing value because quite often we fail to recognize the cultural aspects of the individual. We give examples of individuals who, for instance, do not do a lot of talking. We also look at the gender components within this as well. When you look at the difference between men and women, one of the things you do understand is that in our system, we quite often ask our patients to divulge. We ask our patients to express themselves. We ask our patients to give us their emotional insights, bring them out for us. But what we sometimes fail to realize is that the gender raising is a differential. That for men, it is the opposite of what many men have been taught to do all their lives. They've been taught instead to do the opposite, that they should man up. They should not discuss things. They should act like nothing is going on. It's further promoted when they go into the service. You know, in the service of the country, promote, promote, promote. And what tends to happen is the traumas, the experiences get pushed further under. The last piece here sparks a story from Baltimore, Maryland. Currently, we are working in Baltimore, Maryland, and many of you may be familiar with the history that has gone on with Baltimore. In 2015, they had significant riot based on the death of a person in custody by 5 police officers that were subsequently charged for that particular component, but all 5 were acquitted. There were riots that ensued from that particular element, and what is interesting about it is I remember seeing it on television, and I noticed at one point that a reporter was called in to address one of the rioters. And she ran up to this rioter who at the time had a Molotov cocktail in his hand, but it was not lit as yet. And she shoved the microphone in his face, and she said to him, and the young man who was killed was named Freddie Gray, and she said, "Why are you being so destructive in your own community? Is it because of Freddie Gray?" And he looked at her and he said, "Who's Freddie Gray?" When we understand and recognize historical trauma, what we also realize is that in many communities, there is community trauma. In many communities, there are also historical components, things that have languished within the communities that have been resultant to individuals not having an outlet, not having a way to vent, and it comes out in an aggressive form. That helps us to better understand why it's important not only to recognize and appreciate it, but to also offer individuals that relief, that alternative. So when we move into the standards, we just get into a couple of things to remember. Now, on the Oprah segment that we've made reference to already, one of the things that Oprah said almost immediately on the first interview was she now understands that it's more important to discuss with individuals what happened to you instead of what's wrong with you. And that's such a powerful piece because as we look at the semantics and how we deal with individuals, whether they're male or female, the way we address individuals can make or break situations immediately. When we start to go down the road of what's wrong with you instead of what happens, it's almost reflective of the way that we were ourselves raised. Many of us, I'm sure, had our own parents say to us, "What's wrong with you?" But normally in that tone and in the words itself, it triggers in our brain not a positive response. Now, I've been a psychiatrist for 38 years, and I'm still waiting for the time when I ask a person what's wrong with them. And they will say, "Well, you know, doc, I'm schizoaffective disorder. I get angry every once in a while. I don't take my medicine like I should, and I don't attend any of the clinic appointments." I really would be shocked if that were to come out that way. What generally happens is if I say, "What's wrong with you?" the response I get back, as many of you know, is usually nothing or "What's wrong with you?" And either one tells us that the language is important to keep in mind, how we address individuals. I've worked in a number of correction facilities, and I can't tell you the number of times I've actually asked an inmate, "What happened to you?" And generally the first response is what their crime was. But when they understand the question, they begin to give me examples. And as they give me examples of what happened to them, at the end of 15, 20-minute conversation possibly, I tend to get this question: "Dr. Sims, do you have a practice outside of the jail? Because when I finish my time, I want to come talk to you." Why is that? Well, it's that way because that person feels, and they will say this many times, that's the first time anyone has ever asked them questions and listened without judgment and wants to hear what happened. So we need to look at the power behind that. Because as Oprah had pointed out, it's extremely important because it opens doors. It doesn't close them. As you ask people what happened, they begin to understand that you're different than mom, dad, grandma, grandpa, whoever has intervened earlier to say, "Stop it." The power of "stop it," as I like to joke with individuals, is in that same premise of what's wrong with you. Because many times in our frustration and our inability to really find alternatives and ways to get people to cease behaviors, we simply say, just stop it. And how effective is that? The other premise under things to remember is that symptoms quite often are adaptations, and they're adaptations to traumatic events. What's key to understand in the second premise is that it's when those traumatic events often occur that can alter that person's adaptability. What this means is that the earlier the experience of these traumatic events, and in some cases, the development or the experiencing during a time before language is formed, can have a profound difference in how the person responds as to later when the language is formed, when the person has more cognitive abilities, when they're able to kind of weigh things one way or the other, how they would adapt at those particular points in time. What we do know about adaptive symptoms in terms of adaptation is that they tend to be not tolerated well by a lot of us. And this is an understanding component as we interact with individuals who don't want us in. If a person has verbalized that they do not want to share, and we persist, quite often they will show us that if we're not listening to the words that they're saying, they have displays of behavior. We also have some that come in with a number of behaviors already indicating that they don't even want to dialogue with the person. So what we do is remember that all of this has meaning, that it is not just about the fact that these are aversive adaptive behaviors that we see, but that those aversive adaptive behaviors mean something. The third and last component in this slide talks about healing, and healing happens predominantly in relationships. And we know this because in the healing process, we're not just talking about sexual relationship, we're talking about connection. We're talking about what happens when you actually get in contact with someone who establishes a connection. In William Kelbrew's situation, his therapist established a connection, but he also points out that one of the biggest persons in his life was his guidance counselor, who didn't do therapy with him, but simply connected on the value-based system. William liked sports. His guidance counselor liked sports. When they connected on the values, and they established that form of relationship. So relationships, as you well know, can be very powerful in how we address one another. So let's look at other things to remember. You heard me say this a little while ago, but all behavior has meaning. The reason why I put it on this slide and put it separately is because I want you to focus on that for a second. Look at the treatment strategies that we have out there, and quite often understand that the people with the least amount of power are left with having to make decisions that quite often affect all behavior as meaning. We know that regardless of behaviors we see in individuals, there's something behind it. The problem is many of our systems get frustrated by the behavior and then say there's nothing we can do about that behavior. I did a group meeting in Adelaide, Australia, with a forensic hospital there. And they took me on a tour, and first thing that they showed me was their forensic unit. As I walked through the unit, there were 18 individual rooms on one side of a corridor, but on the other side of the corridor, there was one single room. It had its own day room, and they had its own courtyard. And I inquired about it, and they said, oh, that's for him, for one person. And immediately, my brain began to flow with, my goodness, this must be the most horrible person that you've ever seen in existence, until I met him. He was a fairly nice guy, very open with us. So I went back and I asked him, why is he isolated there? And they said, we can't work with him. We can't deal with him. So I inquired again, specifically, what is the issue? And it ended up that this young man, they decided to do all these interventions because they couldn't place him in the area with the regular patients. If they placed him in the area with the other patients, he would incite them to riot. He would tell them, don't do what the staff says. Stand up against them. So they built him an entire unit. But no one asked why. No one asked the story behind it. When that was asked, it was determined that his mother, who was from the United States, was living in Florida, wanted him to be transferred. He had inquired about it, but the staff had done nothing to make any changes or even address it. So it became something where all behavior has meaning, has a good premise to it, but you've seen it, I'm sure, in many areas in which you've worked. Here's a piece that you usually run with challenges. Those of you that are working in the trauma-informed environment already and trying to make transitions all understand that people view this next element in many different ways. The practicing of comfort versus control is a completely powerful piece, and powerful in a very plausible way. What you're doing when you're practicing comfort is you're flipping the script again. And many of the trauma-informed perspectives are actual paradigms for a lot of organizations. Because what you're asking them to do is not exert the initial control as the only measure of intervention with that person. When you practice comfort versus control, what you are saying to that individual is that in an empathic sense, while you may not understand what they are experiencing at the time, you are there to help support them. I was at the Delaware State Prison, and one of the things that they had as an intervention method was something that was called 15 minutes hands-off. And 15 minutes hands-off simply meant that if a person was triggered, if they became hypervigilant, they would call the COs and the response team, and they would gather, but no one would touch the person. They would simply stand there, and they would talk to the person, but no one would put their hands on them. And that person had the ability to verbalize whatever it is they wanted to verbalize. And what they discovered is that it functioned almost in a bell-shaped curve, that as the person increased their agitation, it would reach a plateau. And after the plateau, it would begin to decline. And at that decline was when people stepped in and began to intervene more. What can we do to help you? How can we work this thing out together? And they found that exerting it that way also had the reverse effect of protecting the staff. Because I don't know very many places outside possibly of corrections or otherwise where the behavior is part of the training that people really want to become aggressive with the consumers. We're not trained to do that, so the control piece has to be looked at. I want to give you one other example because this is a very relevant one. If any listeners from the great state of West Virginia, there's a wonderful program in West Virginia, and it's called Handle with Care. Now, some of you may be familiar with Handle with Care, but there are two aspects of Handle with Care. There's one premise of Handle with Care that talks about the safe, proper way to put your hands on people if you're going to restrain them. That's not what I'm talking about here. What I'm referring to is a program that was started in West Virginia as a coalition between the West Virginia State Police and the local school system. And here's how it operated. If an event happened in the community that involved a school-age child, the state police would respond. They would do what they were supposed to do to address the situation. But then, if that child either witnessed something or themselves had something happen to them, they would first get their task force together and they would contact that child's school. They would ask to speak to the principal. And here we are really sensitive here, so you can understand this. They would only give the principal two pieces of information. They would say to the principal the child's name and Handle with Care. That principal would then contact the teacher of that child, and they would give the teacher the same two pieces of information, the child's name and Handle with Care. So the next day, as that child would come into the class, they may not be dressed properly, they may not have had breakfast, their behavior may be a bit more agitated. The teacher knows that something happened to that child and exercised more comfort than control. And this is spreading nationally now with a lot of organizations because, again, it doesn't cost money. but it raises awareness that not every bad child that comes into the school system is there with just disruption, that many have had experiences and they don't have a way to vent it. You also want to, under the things to remember, build on successes. It's easy to build on deficits, but you can't build. You can only destroy with the deficits because you remind people of their negatives. The message you're giving them is that you're no different than anyone else. We have a wonderful organization. I love these examples. A group of direct care workers who decided that they were going to flip the script in their treatment strategy. So there were 5 of them and 30 patients, and there were 5 DCWs per shift. This is a really rich place, but 5 DCWs per shift. And what they did was they established a book, simple teal-colored marble book, and on the pages of the book, they put on each page the name of one of the patients. And then the first 5 would come in, they would select 6 patients each, and then they would go out and interact with those 6 individuals for their shift. But they would interact to identify positive behaviors. They would then come back to the book, write the positive behaviors down, and go on about their business. The next shift would come in, they would select their 6 patients each. They would first go to the book on those 6 patients, and they'd look to see what positive interactions were written. They would then go out and continue those, and if they identified any more, would come back and write them down in addition to what was already there. What are we doing? We're building on strengths, not on deficits. And I've already repeated about one does not have to be a therapist to be therapeutic. You definitively want to keep that premise in mind because with that comes empowerment. As people begin to be appreciated for the fact that interventions have taken place, that they have spearheaded, that don't involve the protocol portion, but yielded a safe result, that they're actually heard. So what is trauma? And before we start getting towards the break, because we're probably going to be going to a break in maybe 5 or 6 minutes or 8 minutes or so, but I did want to talk a bit about what is trauma. Now, the Substance Abuse and and Mental Health Services Administration, or otherwise known as SAMHSA, had convened a panel of individuals, and these were thousands of individuals, and they involved all walks of life, trauma survivors, practitioners, researchers, family members, etc. And they were all asked a simple question: what is the definition that you can best embrace that involves trauma? What is trauma as you can see it? And these groups overwhelmingly looked at this particular definition as containing all the components that help identify trauma as they saw it. The first thing I want you to see is what's not highlighted, and it's the first word there, individual. Because what we know about trauma is that one person's trauma does not match the next person's trauma. So you cannot look at it in one sense as lumping it into a category. John Greer, who's a psychologist out in California, once said that if we appropriately addressed trauma, the DSM could be reduced to a pamphlet. Because when we look at a lot of events, they are our individual experiences. So the definition talks about the trauma resulting from an event or a series of events, because what we understand about trauma is that sometimes one event can be devastating for a person, and they can carry that for many years. Otherwise, for others, it may be a culmination of a series of events. And yet, for a third group, there may be individuals that actually have experienced having the trauma in their lives, but are unaffected. And that's not to say that there's anything wrong with any of the three. It's just the diverse nature of how we do things. So the second part of the definition helps us to embrace more why that is. And that is that the experience of the trauma determines whether or not it is traumatic for the person. Because even though a person may have had the same episode happen to them as happened to another, how they experience it may be different. And that's what really defines it. The last piece is about long-lasting adverse effects, because we do know that when people have experiences at any point in their lives, it can directly affect how they function, whether or not their physical well-being, their social well-being, their emotional well-being, their spiritual well-being. And we need to keep that spiritual piece in mind, because in discussions with our patients, we sometimes override that because of fear of talking about religious components amongst individuals. But for many people, regardless of the environments that they were raised in, belief systems are critical. And how many patients have said that this deity who is supposed to spare me, I don't believe in them anymore, simply because where was this deity when I was being raped, when I was being abused, when things were happening to me that weren't happening to my friends and my neighbors? So we need to be poised to be able to address that piece. Now, the effect of trauma simply can be conceptualized as a normal response to an abnormal situation. One of our trauma survivors placed a statement, and she said, we need to understand that we as trauma survivors are just like you, but we just handle things differently. And I thought that was excellent in terms of how she mentioned that. The 3 E's of trauma, as you can see, were pointed out here. The events actually cause the trauma, but it's the experience that will determine whether it's traumatic. And the overall effects include all of the things that we talked about a little bit earlier. Those particular pieces help us to be able to get the web and put it together to where we begin to understand the whole person and what they're experiencing, as opposed to the responses that they're giving us at the end that seems to indicate that they are not able to handle the situations there. These reminders have a lot of pieces that affect us. It affects us because triggering components can be very much around control issues, where people feel they have no control. And hence these particular elements are seen in terms of that visualization of, why change my world? Nothing's going to make a difference. Everyone overrides me. Everyone bosses me. Everyone takes control of me. So the power differential is a significant trigger for people. But one of the powerful pieces that we don't take a lot of look at is the lack of predictable nature, the lack of predictability. That's something that we really want to take a look at. And as we go through the next section, I'm going to be talking about addressing some of those components. We also don't want to forget the biological components, because there are many biological pieces. If you're familiar with Bessel van der Kolk is about body healing. And his text, his most recent book, is called The Body Keeps the Score. He talks about how within our bodies we have all the components that we need for healing. He also makes a joke that in the midst of a person's crisis, we don't need medication stat, we need a yoga mat stat. Because as you look at this, what we do understand is that the body responds to those traumatic elements with responses. These responses tend to go, in a very brief way, they tend to go in the direction of protecting you against life-threatening events, which means that some things are ignored. Our immune system begins to go on hold. Our growth, our reproduction, sexual dysfunctions. People tend to get more sickly. You see skin manifestations. All of these things can occur when people are placed in chronic, stressful situations. So what we know is that trauma lives in our body. And our body has ways to indicate to us that a threat cue is perceived. This is a whole element of taking a look at the biological and neurobiological components that are quite often seen. We understand that in development of a child's brain, what we do know is that if we address the trauma early, we're able to have substantial improvements seen in the individuals that we work with. The prevalence data is clearly indicated here. If you just simply say that it's high prevalence, you would be correct. But I also want to add to this data the prevalence of trauma in the general population, because one of the things that we do see is that roughly 61% of the men in the general population and 51% of the women in the general population have had at least one episode of trauma in their lives. And that's an important determinant
take a look at. You see down the bottom an estimated 10% of women developing PTSD, making it about twice as likely as men. Here's the issue, folks. We look at PTSD and we quite often think about soldiers. And while that's accurate, PTSD is not about soldiers. Yes, it's there, but let's look at the essence of it. When I was doing the studies with Walter Reed, one of the things federally we were able to establish is that roughly 80% of soldiers, male and female, who experience trauma say that the experience of the trauma came from what they witnessed as opposed to what directly happened to them. And that's an important distinction, folks, because what that does is it now takes the lens away from the soldiers and adds to it the lens of the kids that are living on our streets today. We see the prevalence among substance abuse in terms of individuals who report child abuse, who also report trauma histories. We also see in the same element homeless individuals. That number is a 2011 number, but I can assure you it's even higher than 92%. If you assume that any person who is homeless has a history of trauma, you're going to be right 100% of the time. Roughly a third of veterans seeking treatment have PTSD. Very profound things. It promotes why we do what we do. So at this point, if it's okay, I'd like to take a 5-minute break, and we'll get back together and we'll start in on the adverse childhood experiences. Thank you.
Dr. Sims, thank you. So we'll reconvene about 1:06. Thank you. Welcome back, everyone. And Dr. Sims, when you're ready.
All righty. Thank you very much. All righty. Let's go ahead and get restarted again. And what I wanted to do now is just kind of move over into a study that I'm sure many of you are familiar with. This is a particularly striking study, even though it's relatively old in standards. I do want to say before we go further is that this particular study, as I go through the details on it, has been replicated at least twice. One element in Chicago, roughly about 5 years afterwards, and another study that was done in California. I've taken a look at this data and really has exploded it, but one of the most important things to see in it is that the data didn't really change much. Now, the Adverse Childhood Experiences study is a study that began in La Jolla, California. It's a suburb in San Diego, and it was originated at an obesity clinic that was run by Kaiser Permanente. Now, in La Jolla, California, if you look at the population distribution, you'll find that there are very few poverty-stricken individuals. And in this particular obesity clinic, there were over 25,000 individuals. And when you tease out the data, what you see is that a majority of them were college age and really more middle-class individuals. However, Dr. Vincent Politi, who was not a psychiatrist, not an epidemiologist, was running this clinic, and he was having tremendous success. People were losing weight. And why that's important is because when you maintain weight, of course, your prognosis in terms of long-term components happening increases dramatically. And what he noticed is that these folks were doing very, very well. But Dr. Politi also noticed that a certain cohort, a smaller portion of individuals, were not only not losing weight, they were actually gaining weight, and they were dropping out of the study. Now, Dr. Politi could have said, that's such a small percentage, I will take the large percentage that's doing well and ignore the group, but in trauma-informed manner that says all behavior has meaning, he went back to his intake individuals and said, let's take a look at the folks who are not doing well and look at their intakes, and let's see whether or not there are any common threads amongst their intake questions and the responses that each one gave. And they began to see some astounding facts come up. One example of which was they looked at the intakes question, and one of them said age of first sexual contact. And they found in the group that was not doing well or failing the study or dropped out of the study, the average age was 9. And as they saw that, they began to say, I wonder what else is going on. And as they unfolded more intake information, it became so voluminous that he went to the Center for Disease Control, and they acquired an epidemiologist, Dr. Robert Anda, who then joined Dr. Politi, and the two of them began to explode this particular perspective, and they began to look at it in different lenses. And what they saw was the extensive association of shame, guilt, humility, abuse, all of the factors that wrap around traumatic components and how they affect the individuals that we're serving. When you look at all of those pieces that you see there, recurrent and severe physical abuse, emotional abuse, sexual abuse, they begin to come up with a questionnaire. And I hesitate to call it a questionnaire because what I want you to understand is that
the adverse childhood experiences study was never intended to be a questionnaire. It was not to be administered to people. And I think there's a lot of people that are currently trying to use it that way, but you need to be reminded that this is something that was more of an issue for giving you data and comparison studies so that you could then look at your own population and determine from that the prevalence. We already talked about why this study is so important and why it was important to take a look at this, because as you start to affect things early in life, as you saw in the definition, it can affect things longer term down the road. It can lead to severe medical conditions. It can lead to premature death. So what they did was they came up with a questionnaire that actually was 10 questions. And it's a questionnaire because in the design of the study, they identified 17,000 individuals. And they posed these 10 questions to these 17,000 individuals. So what you're looking at is a questionnaire designed specifically for them. And it asks the question during the first 18 years of your life. And what you can do with this is, and I do this with groups a lot, take a look at this and take a look at the people you serve. And ask yourself the question, how many of these individuals that you serve, how many of these questions do you think they could answer in the affirmative? So for everyone that they're able to say a yes to, they get 1 point. Also, if you have time or you want to keep it in the back of your head, how many questions could you answer in the affirmative as it pertains to the study? So during the first 18 years of life, did a parent or other adult in the household often swear at you, insult you, put you down, humiliate you, or act in a way to make you afraid that you might be physically hurt? Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you? Or ever hit you so hard that you had marks or were injured? Did an adult at least 5 years older than you ever touch or fondle you, or have you touched their body in a sexual way, or attempt to have oral, anal, or vaginal intercourse with you? Did you often feel that no one in the family loved you, or thought you were important or special, or your family didn't look out for each other, or feel close to each other, or even support each other? Number 5, did you often feel that you didn't have enough to eat, had to wear dirty clothes, had no one to protect you, or your parents were too drunk or high to take care of you, or take you to the doctor if you needed it? Number 6, were your parents ever separated or divorced? Number 7, was your mother or stepmother often or very often pushed, grab, slapped, and we're going down the road of domestic violence here, or repeatedly hit with at least a few minutes, or threatened with a gun or knife? Number 8, did you live with anyone who was a problem drinker or an alcoholic or who used street drugs? Number 9, was a household member depressed or mentally ill, or did a household member attempt suicide? And 10, did a household member go to prison? Now, you look at these 10 questions, and one of the first things that pops up is what would be the average number that you would think? And you don't have to really post it or otherwise, but just be thinking, how many of these could the people you serve answer? Because the national statistics, when you're doing impoverished populations or any populations, you're finding that the numbers are coming out around 6 or 7. That's important, because when you take a look at what they found, it was profound. Many of you can Google this. There's extensively additional information than what I'm able to present in this short presentation, but I want you to take a look at the data. One of the most compelling pieces of data actually came from taking a look at male children. One of the things they saw was a male child who scored a 6 on this, meaning that they had 6 of those questions answered in the affirmative, had a 4,600% increase in likelihood of becoming an injection drug user as opposed to a male child with an ACE score of 0. Now, why injection drug use? Back in 1998, when this was sanctioned, heroin was huge in La Jolla. So he is basing it on heroin. However, we need to look beyond heroin and look at any substances, because he poses 2 questions. Might the substance itself, and I'm going to substitute it in here, be used for the relief of the profound anguish that goes back to their childhood experiences? And secondly, might it be the best coping device that an individual can find? There were times when in 38 years of prescribing medication or otherwise, I have had people, when they trust me, when my patients trust me, they'll come in and they'll sit down and say, Dr. Sims, I love you your medication, but you know what, your medicine gives me headaches, it screws my stomach up, my sexual life is absolutely zero, but doc, every time I shoot up with heroin, all of my troubles go away. Now, we think about it from a logistical standpoint of view. We think about it from a treatment standpoint of view. We think about it from a compassionate standpoint of view. My argument with them is, of course, I care about you. I don't want you to die. They understand that they could be arrested. They understand they could die. They understand the complications. But when people are seeking relief of anguish, the measurement of that is very difficult and is very personal. And to some, it's the best coping mechanism that they're able to find. But the study went a lot further than that. And one of the things you can take away from this study pretty much is if you start with the statement, the higher the ACE score, the greater, and stop there, you're probably going to be right. Because what they discovered is that, for instance, the higher the ACE score, the higher the likelihood of severe and persistent emotional problems, the higher the health risk, the higher serious social problems, adult disease and disability. They see a higher rate of health and mental health care costs with individuals, a higher degree of poor life expectancy. Let's take a look at this here. Oh, and I want to go back to the ACE score where you had the male child with 6. In that same study, a male child who scored a 4 of the 10 items had a 1,350% increased likelihood of becoming an injection user. Now, of the 17,000 members that were part of this study, 1 in 4 were exposed to these 2 categories. 1 in 16 exposed to 4, but 22% were sexually abused as children. 66% of the women in the study had experienced abuse, violence, or family strife. Compelling studies that led to a lot of discussions of what to do next. You look at this, 2/3 of all suicide attempts, higher degree of adverse childhood experiences. Adult suicide attempts, ACEs are connected with 64%, 80% of child adolescent suicide attempts. You look at the gender separation, women are 3 times as likely as men to attempt suicide, but men are 4 times as likely as women to actually complete suicide. And you look at the inner workings of this, and you begin to see that experiences make the difference. How we address our experiences make a profound difference. In working with the veterans, one of the things that I discovered is when talking to them, many of them were asked to hold things. And we look at this from a militaristic sense to look at debriefing or the lack thereof, but many carry secrets. These secrets may have been of events that they witnessed that they're not allowed to talk about, or things that happened directly to them that they're not allowed to talk about. And even though the war is over, even though the conflict they may have been involved in is no longer there, they still retain it inside. And it's overwhelming for many of them to try to deal with. Let's look at some of the things that we've seen locally in the Florida region. One of the things in the ACE score, they took a look at Florida's juvenile offenders, and they ranked it based on the juvenile offenders and put it side by side on those individuals that were involved in the Kaiser Permanente study. And it's amazing, some of the things that you see, that even in the studies that they did here, in your local area, the juvenile offenders with 4 or more ACE studies or ACE on the ACE questionnaires were profoundly off scale. And it's just amazing when you take a look at this data to understand that despite the age differential, meaning when the study was sanctioned, as opposed to where it is now, you can see that things are not getting better. Take a look at this study here, where you look at it, 50.1% of these juvenile offenders have 4 or more in terms of the ACE scores. What that tells you is a statement I've made before about the drug use fatigue is just one piece of the scenario. Let's take a look at the prevalence of ACE by gender. You take a look at males and females. as you go down the various elements that you saw in those questions, family violence, separation, divorce, and other issues, you see the numbers teased out. Look at the elements under the first category involving family violence. We look at the prevalence of family violence out in the communities, but look at the high degree of ACE indicators in terms of what is happening in real society out there today, right now, as we speak. We don't want to also ignore some of the things that may not be primarily pointed out as traumatic events. But one, and this ranks at 74% of the trauma experiences that you see happen in the United States, and it's under the form of neglect. Neglect is the silent killer of many folks. And when you look at the reasons why, neglect is something that is very difficult sometimes to see. Yes, we do see points where people are locked in closets and not fed and not clothed, not bathed, all of those things, and you can see externally that is there. But many of the kids have neglect that occurs from even a lack of a serve and return during the brain development. When you're looking at neglect that is in the realm of actually the child being present in the room, but not talked to, not interacted with, and how this has long-term deleterious effects. The ACEs themselves are very common, folks. When you look at the prevalence across the studies between men and women, hugely there, but look at under neglect with regards to those who had lack of support, but even under the poverty component. We know poverty is a significant trauma. Let's look at ACEs as they underlie domestic violence. You saw the one teasing questionnaire about that. But women with ACE scores of 4 or more are 500% more likely to become victims of domestic violence. Now, both men and women, however, when you tease out the gender specificity, are more likely to become perpetrators of domestic violence. And again, built on where the data really shows what's happening out in our communities. Look at the ACE score and the risk of perpetrating among the men and women. This is actually supported data of what I just showed you in the previous slide. Now let's take a look at adverse child experiences and the likelihood of greater than 50 sexual partners. The higher the ACE score, the higher the likelihood. When you look at all of these factors, you begin to see that there's a intertwining of a lot of community components that you see every day in your sessions, where you see every day in your treatment strategy, or you may see in your own personal lives. But one thing is very clear: the higher the ACE scores in a lot of these studies, you see this here. Look at the ACE score in an unintended pregnancy or elective abortions. Again, the higher the scale, the higher the degrees and the higher the numbers. Look at sexual abuse of male children and their likelihood. So the earlier or the more experiences that a person has where they've been abused as a male child, it increases the likelihood of impregnating a teenage girl. So the earlier they're actually abused, the greater it actually is. Because when you look at the ages here, you can tease out the specific ranges here. Well, let's now turn our lens a bit, if you will, over to solutions and strategies. What I've tried to do in the time that we've had so far is to give you an overarching component of elements to identify where we are. I think where we need to be is taking a look at now what solutions and strategies we have available. What I'm about to show you really is a small synopsis of it. It's impossible in a small setting. Why? Because everyone out there, you guys are very creative. And whatever I come up with, there are hundreds and hundreds of hundreds more that could be added to it. So I'm not going to talk about specific strategies. What I'm going to talk about is specific attitudinal changes. The first attitudinal change, of course, is to take a look at reverting from what's wrong to what has happened. Now, how do we do that in terms of where our thinking is? We move from the realm of what's your diagnosis to what's your story. And that's so different. As a psychiatrist, I do recall a number of years ago when I had my private practice, I had a young lady come in and she sat down and I asked her who she was and why she was there. And she gave me her name and she said, "Dr. Sims, I'm depressed." And I said, "Wow, tell me about your depression." She said, "Well, I cry a lot. I stay to myself. I get angry very, very quickly. I feel hopeless. I feel helpless." And I asked her how long she had felt that way, and she said, about 6 months. Well, I immediately back then launched into diagnostic realm, and I sought out my DSM, and I was able to pull out a diagnosis of major depression, to which she gently received it. I then started her on a antidepressant, sent her out, and as she came back, she reported that there was no change. She had not felt any different. So I upped the dose of medication because she hadn't had any side effects or otherwise, and sent her out again. She came back the second time and she said, "Not only is the medicine not working, it's now giving me side effects." So I went from that realm to switching the medicine. And then I switched to the third time. The piece that I challenge individuals is, what did I miss? And that's what you see on the other side. I missed inquiring what her story was. After 3 failed trials, I then asked her, did something happen back during the time? And she said, absolutely. But my husband started cheating on me. And I found out about it, and even though he denied it, I keep getting phone calls. I feel angry all the time. I just want to be by myself. I don't think things are working out. I feel hopeless. I feel helpless. If I had known that, the procedures in which I had taken could possibly have been different. Now, one of the things that I want to look at is making sure that my response is not about just putting on the response. Now, please don't misinterpret this as an anti-medication discussion, because it clearly is not. Medication is appropriate. Medication is life-saving. Medication can help stabilize individuals to where the quality of their life is tremendously enhanced. But what we're trying to do is reframe the thinking so that when medication is prescribed, instead of it being the end of our treatment strategy, we need to begin to look at it as the beginning. If we're looking at all behavior as meaning, if you're successful in putting out the adverse behavior, then we're obligated to look at where it came from. And this is the SAMHSA principle, this is trauma-informed care principle that takes a look at prevention. We're looking at prevention, not just how did we get here, but where did it come from? When we understand how powerful prevention is in that scale, we begin to start to look at things differently. We're looking currently at the opioid crisis and the amount of money that's being poured in to put out the response. Get the drug dealers off the street, get the physicians to reframe how they're prescribing opioids, to have tons of Narcan available for individuals so that they're better able to be saved in the midst of their crisis. And while all of those are not bad things to do, folks, what I'm really trying to point out is that you can do all of those and still not settle the problem. And one of the reasons it's not being settled is for the population you are addressing at that point. There is another population who is just starting in to the realm. So if we don't practice prevention, we're not practicing whole treatment with our patients. We look at what are your symptoms. How about changing that lens? How have you adapted? We work with a family clinic at Johns Hopkins, and the family physician there, Dr. Laura Sandler, wonderful person, and what Dr. Sandler chose to do was she wanted to take a certain special population of patients into her clinic. Now, the deleterious term for that they had was frequent flyers. These were people that over and over kept visiting the ERs to the extent that the ER staff became so negative towards these people that they would basically not even say a word to them, bring them in, put them into a room, let them sit there for a few hours and hope that the person just gets tired of sitting there with nothing and eventually leave. This doctor wanted to take that population and do something different with them. And one of the things that she did that was very different but also transformed many individuals, was that she would bring them into the room, and the first question she would ask them is, how do you want to feel? And many individuals have not had that piece asked. So rather than what are your symptoms, how do you want to feel? How have you dealt with what's been going on in your life? Lastly, look at how can I best help or treat you? For many of us, that sounds extremely appropriate. Let's talk about what I can do for you. And that sounds great, but many people don't know what you can do for them. That's why they're there. They're hoping that what you're going to say to them is, this is what my plan is, but to stretch it further, how can we work it out together? And when we work it out together, what are we looking at? We're looking at prevention. We're looking at getting out of a lens where a person comes to you and says to you, I have these symptoms, you give the treatment, and then the person comes back and say, I feel a little bit better, doc, but how long do you think I'm going to be on this medication? Because quite often our answer to that is, for the rest of your life. And if that's true, that sounds very disheartening for many people. Why couldn't our conversation be, let's work together? I'm not sure about how the medication is going to help you, but what I do know is that if it begins to help you and we're able to give you other tools to self-regulate, to find answers so that you don't get the triggers, there is a possibility that we might be able to get you off the medicine, but you give people hope. We have a trauma survivor, a young lady who had 83 arrests and 66 convictions. She lived in the city of Annapolis. She lived under a bridge in Annapolis for 19 years. She was a crack addict. She was a prostitute. She was in and out of jails, hospital systems. This young lady was told she would die under the bridge, die in the streets, die in prison. Today, she's one of the foremost trauma survivors who is out there in the real world, internationally and nationally known. The difference was that people began, as she identified it, to work with her. And she has not been on medication for 15 years. Well, let's take a look at that self-regulation piece, because the self-regulation piece really tells us a lot. What it says is that from a biological standpoint of view, when you teach people about self-regulation, you're giving them new tools. And that's important. That's empowering. It's helpful. It's almost, if you use the old adage about medical hypnosis, one of the aspects of medical hypnosis was to also teach the person to auto-hypnose. And why was that? It was because you can't go home with that person. So when they see the triggers that keep that behavior going, they're able to induce their own state. In the same way, healing has self-regulation. When people don't feel they have choices and you give them alternative strategies, you're empowering them. Because why? You're trying to empower them because the one thing you don't want to do is to let their nervous system stay chronically aroused. When I do the neurobio talks, one of the things that we want to point out, folks, is that infant brain development, which can last for a period of up to 4 years before that brain fully develops. The highest portion of the function of our brain, which is the prefrontal cortex, which has a lot of work on self-regulation, on regulating the emotions, up to 4 years may not even be formed, which means that infants who are experiencing negative experiences don't have the control measure to regulate it. And that's called toxic stress. And under toxic stress, it's toxic because those billions of neurons, the few that are forming and doing what they need to do, are put in the high gear to the point where they literally burn out. And this is during a time when an infant needs for these neurons to develop and to further mature. The other thing you want to do under self-regulatory components is to have a plan to work with the triggers. People aren't always able to tell you what their triggers are. You want to look at those things that arouse individuals, the traumatic reminders or otherwise, because self-regulation is about a plan. For some, it may be something, and we asked one time, there was a gentleman who was a truck driver. And we asked him what things helped to soothe him. And he said, you're going to laugh. We said, well, I don't know. What is it? He said, I love to color in coloring books. We don't know unless we ask. But it's important to know that, because as we begin to start working with these self-regulations, again, we're empowering people. But do not ask if you're not going to place it in place. In many systems I've worked in, we ask people by JACO requirements what things agitate you. They tell you. You're supposed to write it in the chart. You're also supposed to ask them what things soothe you. You put those in the chart. Why? Because they're supposed to be tools to use if that person gets triggered. In many systems, we write it in the chart, and it's never read. Hence, when the person gets triggered, we exercise control versus comfort. Just something to look at. Remember, in these strategies, that symptoms are adaptations. That we try to take the personal piece out of sometimes the adaptive behaviors that people show us. Look also at the social environmental strategies, because when you teach people about prevention, you're empowering them. You're starting to give them options. And you can take this out of the mental health realm and even put it in the physical realm. Because within the physical realm, how many times have we actually approached our doctor, for instance, and said, and it might be me, it might be anyone, Dr. Sims, I have headaches, I'm dizzy, I'm lightheaded, I don't know what's going on, and long story short, I find out you have hypertension. I place you on an antihypertensive, and guess what? It works. You come back, your blood pressure's looking fine, and you say to me, thank you so much, Doc, and you go back out, and a few weeks later, a month later, you come back and your blood pressure's out of control again. And what do? I adjust the dosage. I'm not practicing prevention, because what I'm assuming is that the medication by itself took care of everything. Whereas I didn't walk out the door with you and notice that as you left me, you got in your car and you drove to the nearest McDonald's and you argued with the person because they didn't put enough salt on your French fries. These are things that are preventive strategy. We have to understand it came from a source before we start looking at why things are not improving. Look at the relational, the repetitive, and the rewarding experiences. These teach us things, that we flip the script from negative to positive. We begin to enforce the fact that people have, everyone has, positive components in them that really makes them the individuals that they are, rather than the negative pieces. And the last part, it's repeated several times for its effect. We need to practice. Why? Because many strategies that people ask for, they ask for as a singular component. What they say is, what thing can I do that's going to make a difference right now? And the amazing part about that is that you don't have answers for that. There is no one thing that's going to happen. As a matter of fact, you may find that one strategy you use with a person doesn't work in the next one. Or something you use with a person may work that day, but might not work the next day. So you want to also keep in mind that you keep your options open. Make sure that they understand that it may take multiple times, but work together with that person to ensure that there's a difference. Look at the trauma-informed care perspectives as a universal precaution, folks. We all understand the medical element of universal precautions and our rationale for the utilization of universal precautions. So universal precaution says you don't know. Therefore, you take precautions to prevent the possibility of developing a disease, or that person may have an infection and you may end up getting it. So you wash your hands. You make sure that you keep your environment as clean as possible. In trauma-informed care, we also practice universal precaution. How do we do that? By understanding that when we meet people, we don't know what happened to them. And we don't know quite often how that experience has impacted their behavior. So what we do is we seek to understand, not what's wrong with them, but what happened to them, and try our best not to judge them, because once that occurs, it's ended. When we talked about the connection piece, the connection is so powerful as to indicate something we do every single day can make a difference in how that person connects or disconnects. I ask groups of people, if you are out just walking the street one day and a total stranger comes up the other side of the street and you establish eye contact with that total stranger, what do you normally say? Answers come back. I say, hey, how you doing? That kind of thing. And I pose the question, do you believe in what you just said? And the answers come back interesting because, as you can well imagine, there are people that really do care. There are people that really listen for the response and can generate a conversation. But there are also people that look at this as reflexive. We just answer. And many of you, when we ask about adolescence and connectivity, what we often hear is that adolescents can smell BS a mile away. Well, part of it is not so much the reflection, but the attitude that you see. If you come out controlling, end of story. They see that. Try our best not to re-traumatize. If we don't understand the story, as Brene Brown would put it, we do need to feel with the person instead of at them or for them. We suck at both. So we need to strengthen the empathy components and move away from the sympathy. When you're interacting with individuals, do not compare notes. Do not gauge where you are by where they are, because it promotes you being able to look at them now and gauge how severe you think their symptoms are, as opposed to how they see them. And we've already shown in this why that's not a particularly good thing. Now, I'm going to kind of move towards closure here. So I want to leave some time to just kind of go through these case studies. But I want to talk about another wonderful facility right there in Florida, the Marion County Juvenile Detention Facility. We were contacted, the National Center for Trauma-Informed Care, were contacted a few years back to take a look at the facility, because what was happening in this juvenile detention facility were that kids every evening, without fail, both the male side and the female side were literally rioting. And it was creating problems because these were kids, and the COs there really didn't want to put their hands on the kids. But every time it came to locking them down for the evening, as you would say, in that environment, there were tremendous battles. And the warden there wanted to know what options she would have available. And she called us in, and actually all we did was go in, and we want you to understand this, folks, we don't tell people how to do things. What we do is open the perspectives, and as was the case with Marion County, they came up with their solutions. And this warden, after listening to a similar presentation to what you all have listened to so far, came up with some brilliant ideas. Now, I remind you, if we as the National Center had made the following recommendations, they probably would have laughed us out of the room. But the warden had charge. So what the warden said was, I know what things soothe my own kids. Why can't we do the same thing? Because no one wanted to fight. So what the warden did was the warden actually solicited the help of a CO who was particularly skillful in art, and commissioned that CO to actually come into the cells and paint them. And the picture you see in front of you is actually a cell on the girl's side of this juvenile detention facility. You notice the cinder block walls, you know, still the thin mattress. What you can't see is the toilet that's towards the rear and the big gray door that shuts around it. She had a local community group actually do the little quilt that you see there. And just those changes changed the environment dramatically. You saw kids being further soothed. She did the same thing on the male side with painting each one of the cells. You see another one here. These are just indications, and it's just paint. And the paint, by the way, was donated. So again, when we talk about cost, it was not a significant issue. Let's take a look at that one. You always joke that it's really hard in Candyland to get angry. This one I like from a personal standpoint of view, but I recall because I had actually a fellow colleague come to me and said, you can't paint cells like this, because if you paint cells like this, these kids are going to look at the walls as water and run into the walls. And you can't make things like this up. But the same person then retorted with, and by the way, if you paint this cell to look like this, they'll never want to leave. Well, the understanding is, of course, that these are still cells. The kids do want to leave, but what this did was practice comfort versus control, and they saw tremendous reductions. Now, I want to give you a little bit more to the story because the warden took it a step further. And what the warden did was said, I know what helps my girls at night. So when it came time on the girl side to actually get new pajamas, and what they normally had were gym shorts and a new T-shirt, what this warden did was order long flannel nightgowns and put each of the kids in the girl side in long flannel nightgowns. And a couple of things happened. Number one, the violence level went down dramatically. And the postulate is possibly it's because of several reasons. One reason of which is, and I don't know this from a personal standpoint of view, but long flannel nightgowns apparently are very hard to fight with because you have to use one hand to pull the dress up a little bit before you can, get into a fight. But the other thing was that the COs had a difficult time distinguishing between those they identified as negative, more negative than others. They saw them all as the same. And you saw tremendous things happen just with those changes there. So with that in mind, we've reached right about the point, and hopefully you've had an opportunity to kind of take a look at the case histories. If not, I'm just going to run through it fairly quickly, but I thought what we do in the closing time that we have is take a look at these case studies, because I know for a fact that you guys have some amazing ways of working with individuals. And I'm just curious, because what will happen is you will have people that will show different responses, and some out there may be looking for answers. So please keep that piece in mind as we go through these. Now, I'll read through it, and if there are any questions or anything, I think, Leanne, we've discussed this. They're just going to post their questions.
Yes, that's right, and we have had a couple of them come in. And okay, if you'd like, I can go ahead and read one or two of those to you.
All right. Why don't we do that after I just go through the history, if you don't mind?
Sure, that's fine. So you're going to go ahead and review the case study?
Yeah, I'm just going to read it, and then we can go through, after the questions, maybe post some of the questions that were, or responses that were given. Does that
sure,
sound?
that's fine. And are you going to read it? Or would you like me to?
Okay. So in the first case study, this is a case study of Akasha, and this is obviously a made-up name, and she's a new resident in your program. She's resided there for a few days and now still hardly looks up while her two preschoolers are clinging very closely to her. She lived in a car during the summer after losing her apartment. She and her children were unable to access bathroom facilities and arrived at your facility wearing clothes that were turned inside out and sweaty. After 3 days, she and her children still had not showered or changed. Other residents are complaining. A shelter staffer approaches Akasha, extends her hand, and asks in a very kind manner, "Hi, my name is Maria. What's yours?" Akasha doesn't move to indicate that she sees the staff member. Maria continues, "I know it's been hot. Maybe you and the kids would like to use the shower." Akasha then yells, "I don't need a damn shower, and neither do my kids." She leaves the couch and storms towards her room. So the questions that we're posing at this point, what pertinent questions would you want to ask Akasha? And how would you approach her to attain information and history? Okay.
So, Leanne, if you want.
Yeah, that's fine, and we can wait for just maybe a minute here. I think comments are already coming in, so I'll read those as they come in. Okay, that was rather a general response, not specific to the case study. So we'll give it a minute for people to respond. All right, one response has come in. First impulse is to let her go. Come back later and approach friendly again without offer of hygiene.
Okay.
Another response.
Well, if you don't mind, if I could comment on that one.
Yes, of course, please.
I want to highlight the power behind what that person is saying, and I love the response. Come back and approach a second time. Sometimes what we do in the system is we press, and we continue to press, and all it does is move into the agitation. So I love the fact that you can step away. You won't always get the information you need on your first approach, and that's just the nature of it. So I love that response. Okay, go ahead, Leanne.
Sure. And a few people are responding similar to this. What happened to cause the homeless situation? Tell me what went on. Tell me about your story.
There you go. There you go. And that settles it. I mean, that is where the gist of this particular discussion is. And I can tell you, even though the names have been changed or otherwise, I can tell you that that was the approach that was recommended, and they went in and began to ask her what her story was. Now, there's something else I want to add to this, too. Many of our trauma survivors say that if you really want to approach them, please be sure to do one thing, and it sounds like it's a no-brainer, but make sure you address the person by their name. Because many times in a lot of systems, we address them as patient. We address them as you're part of the service or whatever. What really opens that door, it says, in this case, Akasha, my name is so-and-so, and then move into the connection. So
okay. Another one is, what do you need to feel comfortable here?
Perfect. Perfect. I mean, these are things that I'm hoping that others are taking a look at because they are so soothing. I mean, flip the script here. If any of us were ever in a desperate situation or otherwise, or even had a similar exposure as Akasha does, how would those words hit us? Mm-hmm. And we would look at it that way to say, you know, how would I want to be talked to? And you're so right with that. Okay.
And other ones along the lines of, I'd like to hear about where you came from and what happened in your life. We all have a life story, Akasha.
Again, wonderful, wonderful. It's engaging, it's opening the door, and it's allowing Akasha to feel empowered.
And there was another one. I might ask her, I understand that you don't want to shower. However, how could I help you and your children be more comfortable?
Okay. Alternatives.
Cultural setting or living, trauma to bathing rather than shower.
I'm sorry, I missed that last one.
It was a sort of a phrase around her cultural setting or trauma related to bathing rather than shower.
Yeah, absolutely. I mean, what I, again, love about the whole concept is that you're approaching in a compassionate way, and you're offering under the 6 principles choice. Because that's what came out of that last piece that I heard very, very loudly, is you're offering Akasha a choice. instead of saying, tell me about whatever, which kind of ropes them in a corner and says, you don't have any other option. You must share this. And that usually is a trigger for a lot of folks. Okay.
And then it looks like the last one, but in that a similar vein, what can I do to help you? Do you have any specific needs right now that I can assist with?
Yeah. Again, what are you doing? You're helping her to become a part of a team. This isn't about what can you do for me or what can I do for you, but what can we do together to help you to work towards the goal that you're looking for. A part of the problem is that in the beginning when you saw this, maybe you and the kids would like to use the shower. As most of us probably would hear that question, it would be, oh, so you think I need a shower, even though they do. But the key is it's given more as a command as it does anything else, and it's felt that way. So you see that outcome. Okay? So I know with the limited amount of time we have left, and this is, I never thought it would be this way, but it actually has moved very fast. I do want to move to Hector. Why? Because in this particular case, U.S. Army veteran, 48 years old, been intermittently homeless for years. And after serving in the military, he started cooking in a local restaurant. The work was physically taxing. He was injured there and is now disabled. So he receives Social Security disability payments and Medicaid. English is Hector's second language. And although he's verbally fluent, he has difficulty reading and writing English. He comes from a close-knit family that is offering him shelter, but they only have room for him temporarily. Hector suffers from hypertension, congenital liver disease, and type 2 diabetes. He has limited mobility due to painful osteoarthritis. He reports feeling depressed and anxious about his housing and health and fears being a family burden. Hector lacks a primary care provider, and his limited English skills have made it hard for him to negotiate both medical and social resources. Now, he lost his Medicaid card and been unable to obtain a new one. He does not feel capable of advocating for himself. So really the one question you pulled out here kind of stretches a bit. If you were to work with him with all of the things that you've heard, how would you best engage him in working towards his long-term goal? And what, if any, preventive strategies would you recommend to assist him? So that's a broad question, I realize, and we may not have time to really address it in total. But if there have been any responses, I really would love to hear them.
We'll give it a moment, Dr. Sims. All right, we do have one comment. Ask what he wants for an outcome, then work from there.
And what does that sound like, folks? It sounds like Dr. Laura Sandler. And that's perfect. I mean, again, he has an idea of where he'd like to be, but do you empower him enough to have that voice?
Here's one. Attend a veterans fair where all of the concrete needs can be applied for and met.
Absolutely. I see one on my screen here that says assign case management for extensive intervention and engage the VA as well. All wonderful choices. What you're doing is you're taking his limited ability to speak for himself and you're becoming a team member with him. Instead of telling him what to do, you're saying, let's work it out together and get him engaged. He's going to be more positively engaged when he's not told, walk over to the VA and tell them you're here and this is what you're going to do. Beautiful. Okay.
And then another comment regarding the Veterans Affair to arrange to go with Hector or make certain he has a translator so that all aspects are clear.
Mm-hmm.
And then a VA peer recovery specialist if he is interested in that.
Well, give that person a huge applause. If the theme changes that have happened in the veteran status is the veterans are now becoming much more powerful with their peer support systems. Mm-hmm. There's a program in Tennessee where they actually purchased a hotel, and their whole purpose is to use the veterans, some of whom are peers, and they go out to the community because they connect better with the other veterans than we do. So as they go out, they'll actually invite them to come to this hotel. They receive, breakfast, they get to talk in a group setting, and if they so choose, they become part of the services, and the amazing response that they're actually getting.
And then Dr. Sims, just bringing it in for a landing, one person did suggest that Hector be asked if he preferred to speak in Spanish.
Thank you. Thank you. Perfect. Because
so there you go. We have a lot of smart people in the audience today.
Well, the truth be told is I said in the beginning that I wasn't an expert in this, but I have heard so many people that have talked about ways to engage and how to engage. And it's just wonderful to be able to hear folks who get it and are moving down it. So I want to thank everyone for allowing me this time and giving me the opportunity to speak to you on this. And I just wanted to leave you with my contact information if anyone needs it. I will say to you, if you have any questions or otherwise, please email me. The telephone, I am in my office probably once every 3 months. So if you want a response back, if you don't mind, send it to me based on my email address. All right, Leanne.
All right, and Dr. Sims, we thank you for joining us today and sharing your expertise with the group. We very much appreciate it. And if you're ready, I'm going to take control of the presentation back and wrap up with some closing remarks.
Very good. Thank you.
And I hope that people who are interested were able to access the case study 1 and 2 documents. We will try to also make those documents available as part of the training material that is on the FATA training library on the Resource Center. So I just want to remind everyone that when I conclude today's webinar, your browser is going to take you to an evaluation on FATA's new website. And if you want to receive your statement of credit or a report to CE Broker, please do complete the evaluation for us. Oops, that went too far. Hold on. There we go. You will be prompted to register or log in to complete the evaluation, and you can certainly register as a visitor. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, please do provide an accurate Florida Department of Health license prefix and number at least the first time that you register with us. After you register, you will be directed onward to the evaluation. Do note that the evaluation does close at midnight on Monday, April 2. You will get a second opportunity to complete the evaluation. If you have to run off and do something else, so that's fine. You're going to get a second opportunity to complete the evaluation through a follow-up email in about 30 minutes. And just do note that it will come from FATA on demand. And then after we conduct our verification of your attendance and the evaluation, we will post your statement of credit and send you an email to let you know. That email is going to come from info@fata.org. And then finally, I'd like to thank all of our participants for joining us today on the webinar, and would also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So everyone, have a wonderful weekend, have a great rest of your day as well, and please hold for the evaluation. Dr. Sims, thank you.
All right, thank you.